What if a burning, bleeding ulcer inside your bladder, something that's caused you years of just agonizing pain and, endless doctor visits, had absolutely nothing to do with your bladder at all?
Right, which sounds totally counterintuitive.
Completely.
Yeah.
But what if the real culprit was actually just a single loose ligament, like an inch away, tugging on a nerve and completely tricking your brain?
It sounds like an episode of a medical mystery show, but it's a very real, heavily documented phenomenon when we look at the biomechanics of the human pelvis.
Yeah.
Because we kind of have this habit of looking at the body in these isolated silos, right? Like the bladder is strictly the urologist's domain, the uterus is the gynecologist's.
Right. Everybody has their own specific territory.
Exactly. But the structural network holding all of that together is deeply intertwined. So when the scaffolding fails, the entire system misfires.
And that structural scaffolding is exactly what we are exploring today. So, welcome to the deep dive. We're looking at a stack of sources today that focus entirely on urogynecology and really the hidden architecture of the pelvic floor.
Yeah, we've got some fascinating clinical guidelines, anatomical studies, and medical texts to go through.
We do. And we're going to see how the system works, but more importantly, how it breaks down. And our core mission, the big question we're anchoring this whole deep dive around, is actually super specific.
Right, and it's one that affects millions of people dealing with incontinence or chronic pelvic pain.
Exactly. We want to know, can a pelvic floor physiotherapist actually identify asymmetric urethral support just by using their fingers during an internal exam? Or, is that structural damage just so complex that clinicians are essentially flying blind without high-tech imaging?
It's a huge diagnostic debate, and to really get to the bottom of it, we first have to understand the physical environment we're even dealing with down there.
Right. Set the stage.
Yeah. The sources detail two major foundational concepts for this. There's the hammock theory, which was introduced by Delancey, and then the integral theory developed by Petros and Olmsted.
And both of these theories, from what I read, they seem to completely move away from this old idea of the urinary tract as just rigid plumbing.
Yes, exactly.
They describe the urethra, the tube that carries urine out, as this flexible structure that just rests on a supportive layer.
And a hammock is honestly the most accurate visual you could ask for. The urethra doesn't just hang in empty space inside you. It rests on a layer of tissue made up of the anterior vaginal wall and this sheet of connective tissue called the endopelvic fascia.
Okay.
And that whole hammock structure is suspended between the pelvic bones and the levator ani muscles. So normal control over your bladder relies entirely on the tension of this hammock.
It really reminds me of a suspension bridge. Like the bridge can only handle the weight of heavy traffic if the underlying cables actually tense up to absorb the load, right?
That is a perfect analogy, because that tension is everything. If we look at the dynamic forces, when you cough or sneeze or lift a heavy box, you create a massive spike in intra-abdominal pressure.
Right, everything squeezes down.
Exactly. The organs get pushed downward. So to counteract that downward force, your deep pelvic floor muscles have to instantly contract. They pull that fascial hammock totally taut.
So the urethra basically gets sandwiched right between the downward pressure of your abdomen and the upward tension of the hammock.
Yes. It forcefully compresses the tube shut so you don't leak urine. But if those supporting ligaments are overstretched, or maybe the fascia is torn, the hammock stays loose.
Oh, I see.
So when you cough, the urethra has no firm backing to compress against. It just yields to the downward pressure, the tube stays open, and boom, the patient experiences stress urinary incontinence.
Which brings us to how clinicians actually figure out if that hammock is doing its job in the first place. Because for decades, the absolute gold standard for assessing this whole complex suspension system hasn't been a high-tech scanner.
No, not at all.
It's been digital palpation, just a physiotherapist using their fingers during an internal vaginal exam. Which sounds, I don't know, it sounds a lot like a mechanic trying to diagnose a complex suspension issue in a car entirely by feel, just pushing down on the bumper to see if the shocks bounce back right.
It does sound basic, but touch really is the foundation of pelvic floor physiotherapy. And it's actually a highly systematized process. They use these scoring methods, like the Brink score or the perfect scheme, to actually quantify how those hidden muscles are working.
Yeah, I noticed the perfect scheme in the clinical notes, and it looks incredibly rigorous. It's an acronym, right?
It is, yeah.
It breaks down into power, endurance, repetitions, fast contractions, and every contraction timed, Honestly, it reads like they're acting as a specialized personal trainer for your pelvic floor.
That's exactly what it is.
Yeah.
They're mapping out the precise physiological capabilities of the levator any muscles. Like power is usually graded on a modified Oxford scale from 0 to 5. 0 is no contraction at all, and 5 is a super strong lift against the clinician's fingers.
Okay, and then endurance is testing the slow twitch fibers.
Right. They're timing how many seconds you can hold a maximal contraction before the muscle just fatigues and gives way.
And so the fast contractions part, that would be testing the fast twitch fibers, the ones you need to fire instantly when you sneeze so you don't leak.
Exactly. They ask the patient to do these really quick 1-second flicks. But beyond just grading the muscles, clinicians actually use their fingers to perform what the literature calls simulated operations.
Yes. That term, simulated operation, totally caught my attention. It sounds like surgery, but the texts describe it as just a mechanical test right there in the exam room.
Yeah, no scalpels involved. Basically, if a patient leaks when they cough, the clinician takes a finger or sometimes a tool like a hemostat clamp, and they push up on the vaginal wall in a very specific location.
So they're manually mimicking the support of a surgical sling.
You got it.
Yeah.
By physically lifting the tissue near the mid-urethra, they are temporarily acting as that missing ligament. Then they ask the patient to cough again. And if that manual lift stops the leakage,
Then they know that's the spot.
right, it confirms that a structural laxity in that exact spot is the mechanical root of the problem.
It essentially proves the integral theory in real time.
Yeah.
You restore the tension, you restore the function, which, by the way, really highlights for the listener why going in for a physical baseline assessment is so crucial.
Oh, absolutely.
Because a lot of patients are just told by their doctor to go home and, do Kegels.
Mhm.
But without an internal exam, you have no idea if your hammock is actually engaging correctly.
It's so true. Many people unwittingly perform Kegels by just clenching their abs or squeezing their glutes. Or worse, sometimes they bear down, which actually increases abdominal pressure and actively damages the pelvic floor even more.
Oh, wow. So they're making it worse.
Yeah. So the digital exam verifies that the correct deep muscles are firing.
But this brings us right to the core tension in our sources and our main focus for today. Because touch is clearly vital for establishing a baseline, sure. But the human finger has a diagnostic ceiling.
It definitely does.
Right, like if the hammock is damaged in a really complex way, say the muscle is torn on the right side but perfectly intact on the left, can a physical therapist actually feel that asymmetric urethral support during an exam?
The clinical data gives us a very clear answer to that, actually. And the answer is that the finger is highly limited when it comes to mapping asymmetric defects.
Really? So they can't tell?
Well, the sources highlight this specific study of 72 women. It was designed to test if digital assessment could accurately predict levator avulsions.
An avulsion is a tear, right?
Right. It's a severe defect where the muscle actually tears away from its insertion point on the pubic bone, which happens a lot during childbirth.
Yeah.
So the researchers wanted to see if the physios could feel the tear.
And then they cross-reference those physical exams with high-resolution ultrasound to see who was actually right.
Exactly. Now, the physiotherapists used this specialized palpation technique where they measured a parameter called the width between insertion sites. By feeling the gap between where the muscle should attach on the bone, they found they could significantly improve their overall detection of these tears.
Okay, so they can feel something is wrong. But the study drew a really firm line in the sand regarding the asymmetry part.
Yes, it did.
The researchers noted that this digital measurement could not reliably distinguish between a unilateral avulsion, meaning damage on just one side, and a bilateral avulsion, where both sides are torn.
Exactly. A physical therapist can feel that the general architecture is compromised. They can identify a widened gap or a lack of resistance, but the actual topography of the tear is just too subtle.
It's buried, right?
Yeah, it's buried under connective tissue, so a finger just can't accurately trace its borders on one side versus the other.
So wait, if the diagnostic ceiling of a finger is really that low for complex asymmetric tears, and we have imaging technology that can actually see it, why is a manual exam still the standard first line of defense? I mean, are clinics just resistant to changing their habits, or is this an equipment thing?
Honestly, it's a combination of both. High-quality pelvic floor ultrasound requires very specialized training to read, and the equipment is expensive. But also, the manual exam provides something imaging just cannot do: tactile feedback.
Like feeling the muscle tone.
Right. Assessing resting tension and seeing if the patient has the neurological ability to isolate the correct muscles on command. Touch is indispensable for rehab. It just fails at high-resolution structural mapping.
And the subjective nature of touch also seems pretty problematic for surgical planning, right? The sources noted that digital exams suffer from poor repeatability.
Oh, absolutely.
Like different physiotherapists might give the exact same patient slightly different Oxford scores, just depending on the size of their fingers or how they interpret the muscle resistance.
Which is exactly why the field of urogynecology has seen this massive shift toward pelvic floor ultrasound, or PFU, specifically transperineal or transvaginal 2D and 3D ultrasounds. These tools totally remove the subjective guesswork.
The transition makes total sense, because using a finger to map an asymmetrical tear feels a bit like reading a topographical map in the dark by just running your hands over it. Ultrasound literally turns the lights on.
That's a great way to put it.
And unlike an MRI, where the patient is lying completely still in a tube, this ultrasound is dynamic.
The dynamic aspect is what revolutionized everything. The ultrasound probe is placed externally on the perineum, or just at the vaginal entrance, and then the clinician can watch the internal structures on a monitor in real time while the patient actually performs the Valsalva maneuver.
Which is bearing down or coughing, so they can literally watch the hammock fail under pressure.
Yes. And because they can visualize the entire levator hiatus, which is the gap where the muscles wrap around the pelvic organs, the ultrasound easily categorizes asymmetric defects.
The machine sees exactly what the finger couldn't differentiate.
Right. The sources point to this major study by Masada and colleagues involving 359 women. Using 3D ultrasound, they successfully subdivided patients into highly accurate anatomical categories.
Like D0, D1, D2.
Exactly. D0 for no defect, D1 for a unilateral asymmetric defect, and D2 for a bilateral defect.
And beyond just getting better data, the sources detail how ultrasound is replacing some older diagnostic tools that just sound incredibly unpleasant.
Oh, you mean the Q-tip test?
Yes, the Q-tip test.
Yeah.
It was highlighted as a primary method historically used to test for a hypermobile urethra. And the mechanics are straightforward, but wow, it sounds invasive.
It really is. A clinician takes a sterile, lubricated cotton swab and inserts it directly into the urethra, pushing it all the way back to the bladder neck, and then they ask the patient to cough.
Ouch. And because the internal end of the stick is anchored near the bladder neck, if that hammock is loose and the bladder neck drops, the part of the stick sticking out of the body acts as a fulcrum and swings upward.
Right. The clinician visually measures the angle of the stick. If it shifts upward by more than 30 degrees, it indicates significant urethral hypermobility.
It relies on using a wooden stick as an internal lever. That is wild. I am so glad ultrasound replaces that with just precise geometric imaging parameters.
Much better, right? Now we can measure BND, or bladder neck descent, using ultrasound coordinates. If the bladder neck drops more than 24 millimeters under stress, it indicates a failure of those supporting ligaments.
Let's just put a visual to that for a second, because 24 millimeters is essentially an inch. When these patients cough, their internal connective tissue is so lax that the entire base of their bladder drops an inch downward into their pelvic cavity.
And it doesn't just drop straight down either, it rotates. The ultrasound also measures the URA, or urethral rotation angle. If the angle changes by more than 41.56 degrees, the diagnosis of hypermobility is fully confirmed.
A 41-degree rotation is nearly a 45-degree angle shift inside the body. The urethra is fundamentally pivoting off its natural axis just from coughing. You can only imagine the intense shear forces that creates on the delicate tissues down there.
It causes profound mechanical strain. But this is actually where the clinical data takes us into completely different kind of mind-blowing territory.
Okay.
Because we have this ultrasound data showing us these severe anatomical shifts, right? The bladder dropping, the angles rotating. It makes perfect sense that this mechanical failure causes urine to leak.
Right, the plumbing is bending.
But reading through the integral theory sources, there's this clinical observation that shifts the entire paradigm. Surgeons started using these advanced diagnostics to identify and repair the broken connective tissue to cure incontinence. But when the patients recovered, they started reporting something totally baffling.
Their severe chronic pelvic pain had completely vanished as well.
Yes.
Which begs the question, why would fixing a mechanical leak cure a complex neurological pain issue?
And this brings us to posterior fornix syndrome, or PFS. It is perhaps the most profound implication of the integral theory. PFS links structural laxity in the uterosacral ligaments. Those are the thick bands of connective tissue supporting the back of the uterus and the upper vagina.
Right.
It links laxity there to a cascade of symptoms that seem entirely unrelated to ligaments. We're talking about severe bladder urgency, frequent nighttime urination, and chronic unexplained pelvic pain.
And the connection, from what the texts say, lies in the visceral nerve plexuses. These are dense networks of nerves running all throughout the pelvis, transmitting sensory information to the brain. And crucially, those nerve networks are physically anchored to and supported by those exact uterosacral ligaments.
Bingo. So if those ligaments become overstretched or damaged, maybe from childbirth, chronic coughing, or even just age-related collagen degradation, they lose their tension.
So they go slack.
Right. They can no longer support the physical weight of those nerve networks. So gravity, along with just everyday movements of the pelvic floor muscles, begins to mechanically pull and stretch those unsupported nerves.
The nerves are put under constant physical traction, so they start firing off distress signals to the brain.
But here's the catch. The brain misinterprets the origin of the signal. Because these visceral nerve networks also branch out to innervate the pelvic organs, the brain just assumes the pain is originating from the end organs themselves.
Oh, wow.
So the patient feels intense pain in the bladder, the rectum, or the lower abdomen, even though those organs are perfectly healthy. It's a classic case of referred pain triggered by a mechanical failure.
That is fascinating. And it also explains the overwhelming urgency to urinate, doesn't it? Because the lining of the bladder, the urothelium, contains stretch receptors that normally signal the brain when the bladder is actually full.
Exactly. Those stretch receptors require a firm base of support from the vaginal wall and the underlying ligaments to function correctly. If the ligaments are loose, the pelvic muscles simply cannot stretch the vaginal wall taut.
So the tissue sags. And that mechanical sagging physically pulls on the stretch receptors in the base of the bladder. The receptors fire prematurely, and the brain interprets the mechanical sag as a sudden, desperate urge to empty a bladder that might actually be mostly empty.
You nailed it. The hardware is physically unsupported, causing the neurological software to glitch. And the most striking validation of this mechanism is documented in the Scheffler discovery.
Yeah, this case study is just incredible. So it was a 73-year-old patient diagnosed with a Hunter's lesion, which is a severe bleeding ulcer on the inside wall of the bladder. And traditionally, that's viewed as a primary bladder disease, right? Like an inflammatory condition of the organ itself.
Right, and her pain was immense. Standard treatments aimed directly at the bladder were likely failing her. But Dr. Scheffler and his team approached her case through the lens of the integral theory.
They hypothesized the ulcer wasn't the primary disease.
Right. They thought it was a secondary symptom. So they bypassed the bladder entirely and performed a surgical repair on her uterosacral ligaments instead.
And the mechanics of that surgery are fascinating too. They use a specialized tape that acts as a scaffold. When they insert it along the damaged ligament, it provokes a mild inflammatory response that causes the body's fibroblasts to migrate into the tape and lay down new, natural collagen.
It's amazing.
It effectively rebuilds and shortens the ligament, completely restoring its original tension.
And by reinforcing that connective tissue outside the bladder, they stopped the mechanical traction on the visceral nerves. And the results were histologically validated. The chronic pain resolved, the urgency disappeared, and the bleeding Hunter's lesion actually healed.
Which is mind-blowing. The mechanical strain on the nerves was causing a neuroinflammatory reaction so severe that it literally eroded a hole in the lining of an adjacent organ.
Yeah.
You fix the structural ligament, you stop the nerve traction, and the organ just heals itself.
It's a fundamental shift in how we understand pelvic pathology. And the crazy part is clinicians can actually test this hypothesis right in the exam room before ever operating, using a very simple diagnostic tool, a speculum.
Wait, a speculum? The speculum test perfectly illustrates this, doesn't it?
It really does. So a patient presents with severe chronic pelvic pain and urgency. The clinician gently inserts the back blade of a speculum into the posterior fornix, which is just the deepest part of the vaginal canal.
And by carefully opening the blade, the clinician artificially restores the lost tension. They literally mechanically prop up the sagging tissue.
Exactly. This physical lift immediately supports the stretch receptors and takes the gravitational weight off those visceral nerve plexuses.
And for a patient suffering from posterior fornix syndrome, the effect is instantaneous. The moment the speculum holds the tissue taut, the misfiring nerve signals just cease. The chronic pain and the urgent need to urinate simply vanish while the support is in place.
It's like flipping a switch. It provides immediate tactile proof of anatomical cause and effect. Because if a mechanical lift with a speculum temporarily cures the neurological symptoms, a surgical reinforcement of that specific ligament will likely provide a permanent cure.
This really brings the entire deep dive full circle. We started by questioning the diagnostic limits of the physical therapist's finger.
Yeah.
And we found that, while digital exams and systems like the Perfect Scheme are vital for assessing muscle power and endurance, they just cannot reliably map complex asymmetric damage.
Right. That limitation really necessitates the use of dynamic pelvic floor ultrasound because ultrasound gives us the mathematical precision, the 24-millimeter drops and 41-degree rotations, to see exactly how the internal architecture is failing under pressure.
And most importantly, the integral theory totally reframes what that structural failure means for you, the patient. A loose hammock doesn't just cause a mechanical leak. It can place physical traction on your nerve networks, creating a cascade of referred pain and urgency that totally masquerades as organ disease.
For anyone navigating unexplained chronic pelvic pain or persistent urgency, this knowledge is a powerful tool. It means that if standard treatments targeting the bladder or the pelvic organs aren't working, the true root cause might be a hidden connective tissue defect.
Right.
Seeking a dynamic structural assessment, whether through ultrasound or a targeted mechanical test, could reveal a completely different path to healing.
It really forces us to look past the symptoms and investigate the scaffolding, which leaves us with a final thought to consider for today. We have seen how a single millimeter scale laxity in a pelvic ligament can place traction on a nerve and silently rewrite the body's pain signals, even eroding an organ.
Yeah, it's wild.
But we exist in a modern environment that is incredibly hostile to our connective tissue overall. We sit at desks for hours, compressing our spines, rounding our shoulders, and adopting postural habits that actively degrade our internal tension networks. If a sagging ligament in the pelvis can cause such profound neurological glitches, it really makes you wonder about the rest of the structural chassis.
Oh, absolutely.
Could everyday postural decay be stretching ligaments in our neck, our back, or our ribs, creating a subtle, constant traction on other nerve plexuses? The next time you experience an unexplainable pain that doctors just can't quite pin down to a specific organ, it might be worth asking if your hardware is simply unsupported, causing the software to glitch.
That is a vital perspective on how interconnected our biomechanics truly are.
Thank you for joining us on this exploration of the hidden architecture. Keep questioning the invisible.